Colon cancer is the third most common cancer affecting Bahamians. Your risk of developing colon cancer is increased if you have a personal history of colorectal cancer or colon polyps, a family history of colon cancer, or inflammatory bowel diseases such as ulcerative colitis. Other factors that can increase your risk of developing colon cancer are low fiber, high fat diets, a sedentary lifestyle, obesity, smoking, and alcohol. You can take steps to reduce your risk of colon cancer by making specific lifestyle changes. Eat a variety of fruits, vegetables, and whole grains. These foods contain fiber, minerals, vitamins, and antioxidants, which may play a role in cancer prevention. Drink alcohol in moderation or not at all. Do not smoke. Exercise with a goal of getting in at least 30 minutes each day. If you've been inactive, start slowly and gradually build up to 30 minutes. Also, talk to your doctor before starting any exercise program. Maintain a healthy weight. If you're at a healthy weight, maintain it by combining a well-balanced diet with daily exercise. If you need to lose weight, ask your doctor about healthy ways to achieve your goal. Colon cancer screening can also help to prevent colon cancer or lead to its early detection when treatment is most effective. If you're 45 years or older, speak to your doctor about having a colonoscopy or some form of colon cancer screening that may be appropriate for you. I'm Dr. Eugene Marcus Cooper. Pay attention to your health. Get the facts and discuss colon cancer with your physician today.
This message is brought to you by the Ministry of Health in partnership with the Public Hospitals Authority.
This morning, we will be looking at medicine and pediatrics. I am your moderator, Dr. Francis Williams. Welcome again, one and all. Our keynote speaker for this morning is Dr. Gary Deal Laroda. He is a graduate of the UWI School of Clinical Medicine and Research, the Bahamas, and is currently a senior house officer in the Department of Internal Medicine. Dr. Deal Laroda is the second author of the presentation that we are about to hear. He is presenting on the prevalence of H. pylori in the patients presenting with uninvestigated dyspepsia in a gastroenterology practice in Nassau, the Bahamas. He is presenting for Dr. Marcus Cooper, and we are happy to have you, Dr. Deal Laroda. Please feel free to take the floor.
Good morning again. I am happy to be here to present my topic on prevalence of Helicobacter pylori in patients presenting with uninvestigated dyspepsia in the gastroenterology practice here in Nassau, the Bahamas. So I have no disclosures. So a little bit about the objectives I plan to go through today. Just wanted to go through the background as to why we opted to do this study, a bit of the definitions and a little bit on the H. pylori here in the Bahamas. Also go over the objective of our study along with the methods and some of the results that we were able to get. So a little bit about why we did the study. So we know that dyspepsia is a common complaint here in primary care in the Bahamas. We also knew that there is a high prevalence of Helicobacter pylori here in the Bahamas. And we do know that Helicobacter pylori is a well-documented cause of uninvestigated dyspepsia. One of the things that we knew would have been a challenge is that the H. pylori testing is something that's not always readily available. And so we still set out to see if we can ascertain the information to say, is there evidence to support empiric treatment of Helicobacter in patients with uninvestigated dyspepsia without alarm symptoms. Like I said, dyspepsia is a very common gastrointestinal complaint. There was a meta-analysis that was done by Ford et al. That showed about average of 20.8% in terms of the prevalence of patients complaining of uninvestigated dyspepsia. This meta-analysis, I think, encompass roughly about over 40 countries, and the range anywhere from 1.8 to 57% based on the country. So we saw that it was very, very prevalent. And so the American College of Gastroenterology, they use the Rome-3 criteria, which defines dyspepsia as experiencing one or more of the following symptoms: a feeling of bothersome fullness, usually postprandial, early satiety, or patients complaining of burning or pain in the upper abdomen. And as you can ascertain from the name, uninvestigated dyspepsia usually refers to patients with these symptoms, whether they're new or recurrent, and those who have not had any investigations done. So a little bit about H. pylori here in the Bahamas. We are fortunate to have some local data, thanks to Dr. Floyd Carter, who has two landmark studies. The first being the seroprevalence of Helicobacter pylori infection in adults in the Bahamas. And that study yielded and showed that 58% of our general population of adults is actually infected with H. pylori. And the second was prevalence of Helicobacter pylori in children in the Bahamas. And that yielded showing 54.2% of children were actually positive for Helicobacter pylori. So profound numbers there, showing that H. pylori is quite prevalent here in our general population. And some of the testing options for H. pylori, I just wanted to go over so you guys are aware. You can use the urea breath test. You can use the serum immunoglobulin testing, antibody testing. There's possibility you can use stool antigen or PCR testing, and the gold standard, which is currently endoscopy with biopsy. So for our study, we use the urea breath test, the 13C in particular. I just wanted to show you guys in comparison the accuracies of these particular tests. The 13C urea breath test has a sensitivity of 96% with a specificity of 94%. And as you can see in comparison, in terms of the stool antigen tests, the standard feces tube had a sensitivity of 92%, with a fecal immunochemical test showing a sensitivity of 94%. The serum testing, although lower, still quite significant with a sensitivity of 80% and a specificity of 85%. So as mentioned previously, these tests unfortunately aren't readily available, especially in the public sector, when we're talking about trying to capture an accurate representation of the population of patients who might be positive with H. pylori. Nevertheless, all right, we went ahead with asking the question and trying to determine what is the prevalence of H. pylori in patients presenting with uninvestigated dyspepsia, especially that subset of population without alarm symptoms. So we went at the study, we conducted a longitudinal study. The patients that were included would have been patients who were 18 to 60 years old. Those obviously would have been complaining of dyspeptic symptoms. Patients presenting to this particular gastroenterology practice between the years of 2018 to 2021. Some of the patients that were excluded would have been, as I mentioned previously, the alarm symptoms. All right, those who complained of severe abdominal pain, vomiting, melena, anemia, or unexplained weight loss for any given time. Patients who were previously treated with antibiotics or proton pump inhibitors. What we did when we had brought patients in for testing is that we asked them 4 weeks prior to testing to hold all antibiotic use. Also with the PPIs, 2 weeks in advance to hold all PPI use. And they were asked to be MPO 1 hour prior to testing. And so, as mentioned, we used the 13C urea breath test, and that particular testing model it uses a solution, a urea solution that the patient consumes. And obviously with the urea being broken down in the stomach, if a patient was to be positive with Helicobacter pylori, that organism would be producing urease. And so then that urea would be broken down into bicarbonate and ammonia. That bicarbonate would then travel via bloodstream to the lungs to be converted to CO2. Then that carbon dioxide can then be expired into the device, which gives us a positive test, and a positive test yields persons who have an increased CO2 levels in the breath test. So a little bit about our findings. So unfortunately, not overwhelmingly positive. We had 227 subjects in this particular study. At the end of it, 42.7% were H. pylori positive. We were able to do a comparison between genders. Not great in terms of showing much difference between the genders, 38.5% being male and 47.6% being female. So, like I said, the numbers not significant per se, but this is an ongoing study for us. And so we will hopefully be able to capture a little bit more. However, as it stands currently, we were able to say that safely that the majority of patients presenting with uninvestigated dyspepsia are not actively infected with Helicobacter pylori. Okay. But one thing that was able to come out of the study was that we would say that the test and treat strategy is good enough to identify patients who will benefit from Helicobacter treatment. Okay, but we would be able to, or we should entertain now other factors that may be responsible for dyspepsia. And so I have listed here of quite a few of the other common causes of uninvestigated dyspepsia. So we could look into things like patients' diet, tobacco use and alcohol use, patients who use certain medications, most notably NSAIDs, as we know. Also to GERD, patients suffering from gastroesophageal reflux sometimes are confused in regards to the symptoms of dyspepsia. So they take GERD for dyspepsia. Peptic ulcer disease and biliary disease as well are two common culprits. Biliary disease, especially cholelithiasis without cholecystitis, can present like dyspepsia. And lower down the list, however, not entirely uncommon though, is that celiac disease as well is a possible cause. And so we had a few limitations study. Unfortunately, we did have a small sample size. All right, and we used a single center. And we also were unable to confirm negative results with biopsy, with endoscopy and biopsy, those particular tests that had a false negative test. So our data did not support the empiric treatment of Helicobacter pylori in an uninvestigated dyspepsia, despite the high prevalence of Helicobacter pylori in our general population. But like I said, the test and treat strategy, which is the international recommendation currently for patients who present with dyspepsia, that strategy is able to reduce inappropriate antibiotic use out there in the primary care setting. Okay, and there's a big chance for us to further study in terms of using a more comprehensive approach in regards to studying, and also using probably a larger sample size and using probably more gastrointestinal centers. Okay, so that is the end of my presentation, quite short and sweet. Here are my references. I would like to open the floor for any questions that you guys may have.
Are there any questions at this time for Dr. DeLaRota? So while persons may ponder, Dr. DeLaRota, we have a number of, or a significant part of our population lives in the Family Islands. They may not have access to serology and testing for H. pylori. They may be symptomatic. What would be the recommendations for these type of patients?
Okay, thank you for the question. So that was one of the questions that we were trying to answer a little bit with this particular study. So yes, we do know that a large population or a large number of people in our country, like you said, might not have the financial aptitude to be able to afford these testings, or like you said, they're not readily available to a certain subset. So we normally would recommend not placing the patient on what we call triple therapy or quadruple therapy. However, in that situation where we're not able to test, but the patient is symptomatic, then I think the guidelines would say that we would still treat either with triple therapy or the quadruple therapy. I do know that Dr. Cooper is in on the call as well, so I'm not sure if he has anything to add in regards to that particular question, especially seeing as he would have had the chance and opportunity to treat patients who are over there in the Family Islands.
Thank you. Dr. Cooper, are you there? Do you wish to weigh in?
Yes, good morning. Can you hear me?
Sure.
Yeah.
So one of the biggest limitations that we did not mention, and I take full responsibility for that, is the site of this study. So this study was done in a private practice, and we know that the prevalence of H. pylori is much higher in people from a lower socioeconomic status who may not have access to coming to a private facility. So the prevalence of H. pylori may be very different and possibly much higher in our patients who come to the public sector as opposed to the private sector. And so our numbers may be skewed. Having said that, it's not unreasonable to, after going through the differential list that we provided, making sure that you address any dietary indiscretions, patients who are smokers, alcohol, using NSAIDs on other medications. After excluding all of those things, it's not unreasonable to go ahead and treat these people empirically with H. pylori therapy, either triple therapy or quadruple therapy, to see if their symptoms improve. So one of the things that we probably would like to do in the near future is to include patients from the public sector in a setting, in a testing method like we're doing now, to see if the prevalence of H. pylori is higher in these patients. And that would indeed justify us treating people, if the prevalence of H. pylori is higher in dyspeptic patients, treating them empirically without necessarily testing prior to doing that.
Great. Thank you so much. So we would like to thank Dr. Deal Lorota, our presenter this morning, and Dr. Cooper for their research. We appreciate it. We're going to move on to our next presentation. Our next presentation is a video presentation. It's a presentation that was done by Dr. Latanya Bell-Adderley, who is a recent postgraduate of the Family Medicine program. Our topic this morning is on knowledge, attitude, and practices regarding dyslipidemia among patients attending several public healthcare clinics in New Providence, the Bahamas. Please, can we roll the video?
Good morning. My name is Dr. Latanya Bell-Adderley, and my research is entitled Knowledge, Attitudes, and Practices Regarding Dyslipidemia Among Patients Attending Selected Public Healthcare Clinics in New Providence, the Bahamas. I have no disclosures. These are abbreviations that will be used throughout this presentation. Dyslipidemia is a modifiable risk factor for cardiovascular disease. Globally, cardiovascular disease is a leading cause of morbidity and mortality. In 2016, cardiovascular disease accounted for 30% of the total deaths in the Bahamas. Elevated cholesterol levels have been associated with an estimated 2.6 million deaths worldwide. And in 2019, elevated plasma LDL rose to become the 8th leading risk factor for death. In 2008, the World Health Organization reported that the global prevalence of raised total cholesterol in adults was 39%. In a systematic review and meta-analysis of population-based studies in the Caribbean and Latin America, Carrillo Larco et al. Highlighted that the pooled prevalence of a raised total cholesterol was 34%. And in the 2019 Bahamas SNP survey, it was reported that the prevalence of hypercholesterolemia or individuals on medication to treat hypercholesterolemia was 25.3%. Increasing public knowledge with regards to dyslipidemia may result in individuals adopting good attitudes and practices towards this pathosis. This in turn may lead to better overall lipidemia statuses and improved health outcomes. Few studies on the knowledge, attitudes, and practices of patients regarding dyslipidemia have been found globally. No studies were found regionally, and no studies have been conducted in the Bahamas. Therefore, this study was conducted to gain insight into this subject matter. It was hypothesized that 55% of participants would have poor knowledge, 40% would have poor attitudes, and 55% would have poor practices. The aim of this study was to assess the knowledge, attitudes, and practices regarding dyslipidemia among patients attending selected public healthcare clinics in New Providence, the Bahamas. The study's objectives were to assess the knowledge, attitudes, and practices of patients regarding dyslipidemia, and to assess the difference in knowledge, attitude, and practices of patients based on their lipidemia status and medical socio-demographic profiles. A cross-sectional study was conducted at randomly selected public healthcare clinics in New Providence between January to February 2023. Cluster random sampling was used to select 5 public healthcare clinics, and at these selected sites, a consecutive sampling of patients was carried out. The inclusion criteria were being 18 years of age or older, residing in the Bahamas, being seen at one of the selected clinics, English speaking, functionally literate to self-administer a questionnaire, and consenting to participate in the study. Persons not meeting the inclusion criteria were excluded. A minimum crude sample size of 381 participants was calculated using Cochrane's formula. When adjusted for a finite population, the minimum sample size decreased to 380 participants. Using a 10% estimated refusal rate, it was determined that 423 individuals would have to be canvassed for the minimum sample size to be attained. Upon obtaining ethical approval and permission from the relevant bodies, voluntary informed consent was obtained from each participant, who were then invited to complete a self-administered 42-item questionnaire in specific areas of the clinical sites to maintain privacy. The questionnaire was adapted from the validated tool used in the study by Diarella et al. Permission was requested and obtained for the utilization and modification of this questionnaire. A pretest of the modified questionnaire was conducted with 10 participants. The data from the completed questionnaires were double entered into a Microsoft Excel spreadsheet. Once the data was cleaned of errors, the file was exported into the IBM SPSS Statistical Analysis Application software. All project-related files were backed up and stored on a password-protected computer. Confidentiality was maintained. Descriptive and inferential statistics were completed. 398 patients were invited to take part in this study. 322 questionnaires were completed, resulting in a response rate of 81%. The majority of participants were between the ages of 18 and 44 years. They were female, single, with a high school level of education, employed, and earned less than $15,000 annually. Approximately 25% of participants reported that they had dyslipidemia. 77.3% of participants knew that there was both good and bad cholesterol, and more than 80% were knowledgeable of the cardiovascular risks associated with dyslipidemia. Overall, 90.7% of participants had a good level of knowledge, and there was no statistically significant difference in knowledge scores based on lipidemia status. However, participants with a vocational and college or university level of education were noted to have higher median knowledge scores. The majority of participants at least agreed with most of the positive attitude statements regarding general lifestyle habits. Additionally, the majority of participants at least disagreed with most of the negative attitude statements. Overall, 88.5% of participants had a positive attitude, and dyslipidemic participants were noted to have a more positive attitude compared to normal lipidemic participants. Better attitude scores were also seen in elderly participants, specifically those 75 years of age or older. Participants in the high-income group were also noted to have a more positive attitude. 30% of participants did not exercise, and of participants that exercised, 62.2% of them exercised less than 3 days a week, and 53.2% exercised for 20 minutes or less. 15.8% of participants ate fruits and vegetables daily, and 11.1% ate fast food on a daily basis. When looking at practice questions that are applicable to dyslipidemia participants only, 68.8% of them followed up with their doctor, and 73.3% of them who were prescribed a lipid-lowering agent were adherent with medication. The modal reason as to why participants were not adherent with medication was that they preferred to use natural remedies. Of note, 16.7% noted that they could not afford the medication or that a friend or relative told them not to take it. Overall, 74.8% of participants had poor practices. Dyslipidemia participants had better practice scores. Increased practice scores were seen with increasing age, and better practice scores were seen in the higher income groups. When controlling for confounders, the predictors of practice scores were noted to be participants' overall knowledge, their attitude, age, sex, and yearly income. In this study, better knowledge was associated with a more positive attitude. Better knowledge was also associated with better practices, and a more positive attitude was associated with better practices. Surprisingly, like Diarella et al., most participants in this study had a good level of knowledge regarding dyslipidemia. Babafemi et al. And Alamari et al. Found that a smaller proportion of their participants had a good level of knowledge. The knowledge scores of participants did not statistically differ based on lipidemia status. This may have been due to the fact that a high level of knowledge was present in both groups. Further research is needed. Unsurprisingly, higher levels of education were associated with better knowledge scores. Similar findings were reported by both Alamari et al. And Saleh et al. Similar to Diarella et al., most participants had a positive attitude. And as hypothesized, dyslipidemia participants had a more positive attitude. No studies reviewed highlighted this relationship. A large proportion of the study participants demonstrated poor practices. This was similar to findings reported by Saleh et al. Conversely, Diarella et al. Found that almost 3/4 of their study participants had good practices. Almost 1/3 of dyslipidemia participants did not follow up with their physician. In addition, little over 1/4 of participants who were placed on a lipid-lowering agent were not adherent with medication. Reasons for non-adherence included financial difficulties and a friend or relative telling them not to take the medication. As hypothesized, dyslipidemia participants were noted to have better practices. Better practices may be observed in this group because they may be conducting these practices as a part of their management. No studies reviewed highlighted this relationship. Further research is needed. Similar to Saleh et al., better practices were seen in the high-income group. Higher income results in more means to provide healthy lifestyle. And this may be a reason why better practices were seen in this group. Further research is needed. Similar to findings reported by Saleh et al. And Alamari et al., better knowledge was associated with a more positive attitude. Additionally, better knowledge was associated with better practices, and in a stronger way, a more positive attitude was associated with better practices. In conclusion, despite the study participants having a good level of knowledge and positive attitudes regarding dyslipidemia, there was a significant gap between these factors and their practices. Factors associated with good KAP scores included participants' age, their educational level, income, and lipidemia status. Recommendations include empowering individuals to facilitate healthy lifestyle practices, patient education and strategies to improve patient practices, strategies to improve the doctor-patient relationship, which may improve patient trust and lead to better adherence practices. Patient social history should also be reviewed so that patients who may benefit from social assistance can be identified and referred. On a governmental and community level, healthy lifestyle campaigns can be launched and policies can be put in place to promote healthy lifestyle practices. Limitations to the study included the COVID-19 pandemic and frequent closures of the Adelaide Clinic, which made it unavailable for the conduct of the study. I would like to acknowledge the following individuals. These are my references. Thank you.
Dr. Bell Adley, recently there's been some information revealed that statins, which are probably the most common medications we use to treat dyslipidemia, may be highly associated with causing diabetes. Do you believe that this has any relevance going forward in terms of patients wanting to medically treat dyslipidemia?
Good day.
Good day.
Thank you for your question. Regarding the fact that some statins have been proven to be associated with the development of diabetes mellitus, I feel as though that in counseling our patients, we do bring up risks and benefits of medications. So basically, it can hinder patients from starting statin therapy, which is the first-line medical treatment that is recommended for treating dyslipidemia. However, there are other options that are available should the patient choose not to take statins.
Thank you, Dr. Bell Adley, for a wonderful presentation. We appreciate you. Thank you.
You're welcome.
Okay, so we are going to move on to our next presentation. Next presentation is on the topic primary care physicians' practices and barriers in evaluating and managing chronic kidney disease in New Providence, the Bahamas. This presentation will be done by Dr. Wilnay Bain, who is also a recent graduate of the postgraduate program of family medicine. The floor is yours, Dr. Bain.
Good morning. My name is Dr. Wilnay Bain, and my research is entitled Primary Care Physicians, Practices and Barriers in Evaluating and Managing Chronic Kidney Disease in New Providence, the Bahamas. Chronic kidney disease is a public health concern. In a systematic analysis for the Global Burden of Disease Study 2017, there were 697.5 million cases of all-stage CKD, resulting in a global prevalence of approximately 10%. The Caribbean had 4.3 million cases, and of that, the Bahamas had 35,741 cases with 93 deaths that year. By 2040, chronic kidney disease is expected to become the 5th leading cause of mortality. Despite this being a global health concern and a risk factor for cardiovascular disease, primary care physicians have raised several concerns around the diagnosis and management of CKD and referral to nephrology services. The objectives of my study were to assess primary care physicians' evaluation and management practices of patients with chronic kidney disease and to determine barriers affecting primary care physicians' overall care of these patients. Physicians were included if they were licensed and working in the departments of family medicine and public health at the community clinics in New Providence, as well as licensed general practitioners, family medicine, and internal medicine specialists working at private clinics or offices in New Providence. Physicians were excluded if they were not practicing medicine at the time of the study, not presently working in New Providence, physicians with subspecialty training, predominantly caring for a specific population group, primarily working in the hospital or in administrative roles. The sample frame consisted of 174 eligible physicians, and the minimal sample size using Cochrane's formula, adjusting for the finite population of 174 physicians, as well as accounting for a 10% refusal, was calculated to be 134. A simple random sampling approach was then used. Physicians were given an anonymous, self-administered 33-item questionnaire that was pre-tested on 10 physicians prior to conducting the study. These physicians were not reused in the study, which took place between October of 2022 to February of 2023. Descriptive and inferential statistics were done using SPSS software. 135 physicians were sampled, whereby 119 questionnaires were completed, giving a response rate of 88.1%. Of the 16 non-responders, 4 had refused to participate. This table shows a demographic profile of the study participants with the mean age being 45.1 years. Physicians were predominantly female and predominantly Black. Approximately half of the physicians were in family medicine, and regarding highest level of medical training completed, MBBS degree was selected at 31.4%. Physicians were almost equally distributed between practice setting, and the mean years in practice was 15.8 years. Physicians mostly reported seeing 51 to 100 patients per week and 10 or less CKD patients per week. Of the 109 physicians who responded to whether they followed CKD guidelines, 67.9% reported that they did. There were 8 types of CKD guidelines that physicians reported to follow, with KDIGO being the most frequently cited at approximately 40%. The most common groups physicians considered at risk of developing chronic kidney disease were people with diabetes, hypertension, and use of nephrotoxic agents. However, at-risk groups that were least commonly selected were elderly, smoking, and obesity. The most common diagnostic test used to identify patients with chronic kidney disease was estimated glomerular filtration rate at 97.5%, followed by ultrasound scan of the kidneys at 73.1%. For urine studies, 24-hour creatinine clearance with total protein was selected most at 62.2%, followed by urinalysis at 54.6%, and urine microalbumin at 52.1%. 82.2% of physicians reported classifying the stage of chronic kidney disease, with 72.2% using eGFR alone, while only 16.5% used eGFR and urine albumin creatinine ratio. Physicians mostly use equations to determine estimated glomerular filtration rate, with CKD-EPI being frequently used among 40.3%. Physicians were asked to choose whether they agreed with feeling comfortable in various aspects of diagnosing and managing chronic kidney disease. Physicians overall agreed with feeling comfortable diagnosing, educating patients, managing medication dosing, avoiding nephrotoxic drugs, managing anemia, and electrolyte disorders. However, for managing bone disorders and metabolic acidosis, responses were mostly neutral at 43.2% and 34.7% respectively. Physicians overall agreed to having available tools to help them diagnose and manage various aspects of CKD. However, responses were mostly neutral for having tools to manage bone disorders and metabolic acidosis. Likewise, physicians overall agreed to having available tools to help their patients understand various aspects of CKD, but disagreed in having tools to help their patients with bone disorders and metabolic acidosis. Physicians were asked to report how confident they are in monitoring and managing various aspects of CKD. Physicians were overall confident, but in particular very confident managing hypertension as a disease. However, for using urine protein results to manage CKD, physicians were equally neutral and confident at 33.1%. The chi-square test was used to determine statistical differences of responses for comfort in diagnosing and managing various aspects of CKD within medical specialty area, medical training, practice setting, and following CKD guidelines. For medical specialty area, statistically significant differences were seen for all aspects except for making a diagnosis of CKD in patients. For medical training, no statistical differences were seen for bone disorders, electrolyte disorders, and metabolic acidosis. Statistically significant differences were seen in following CKD guidelines for most aspects, but specifically when compared to medical specialty and training, it shows statistical significance with making a diagnosis of CKD, managing bone disorders, electrolyte disorders, and metabolic acidosis. For confidence in monitoring and managing chronic kidney disease, statistically significant differences in responses were seen within medical training only for monitoring eGFR, identifying cardiovascular risk factors, and initiating lipid-lowering therapy in patients with CKD. Within whether physicians followed CKD guidelines, statistically significant differences were seen for all aspects of confidence in monitoring and managing chronic kidney disease. A list of 13 perceived barriers were given to physicians whereby they responded with their level of agreement for each. Of the patient-level barriers, physicians strongly agreed with patients' limited understanding, financial difficulties, non-adherence, and fears and/or beliefs being barriers to CKD management. For the provider-level barriers, physicians agreed with primary care physicians' limited recognition, lack of awareness of CKD guidelines, and risk factors being difficult to manage as barriers, but disagreed with primary care physicians' belief that they are unable to improve CKD. For the system-level barriers, physicians strongly agreed with limited time visit, lack of clinical information systems, insufficient support tools for patients, long wait times, and delays in completing investigations as barriers to the management of CKD. There were 26 unique barriers expressed, and the most common were non-adherence with nephrology appointments, limited local CKD continuous medical education, and difficulty of the referral process to the public system. Evidence-based practice has become a standard of care among healthcare professionals. Guidelines provide recommendations utilizing the best evidence available, and they may vary on a specific medical condition depending on international, regional, and local views. The study revealed that approximately 2/3 of physicians follow CKD guidelines, and there were 8 types reported. Differences between these guidelines may impact how physicians evaluate and manage chronic kidney disease, thus leading to progression of disease. The least commonly selected at-risk groups for CKD in this study were elderly, obesity, and smoking. Similar findings were seen in Delatorre et al. Issues is that the world's population is aging, and according to the World Health Organization, by 2030, 1 in 6 people in the world will be aged 60 years and over. The Bahamas has a high prevalence of obesity, and according to the 2019 Bahamas STEP survey, 43.7% of participants had a body mass index of greater than or equal to 30. Smoking is a risk factor in our population, and the percentage of participants who were current smokers and those who had secondhand exposure had increased from the previous STEP survey. The concern is that primary care physicians are potentially neglecting to screen patients because they fall into a category that they do not consider to be at risk of CKD. In this study, there were issues regarding the management of bone disorders and metabolic acidosis in CKD, which affected primary care physicians' comfort managing these complications and lacking available tools to help them and their patients. Similar findings were seen in Sperati et al. Medical specialty, medical training, and following CKD guidelines appeared to affect comfort with diagnosing and managing CKD and its complications, suggesting that training and education has a positive impact on primary care physicians' comfort with CKD care. This study also highlighted low utilization of urine diagnostic tests, low proportion of physicians using eGFR and urine albumin-creatinine ratio to stage CKD, and lower levels of confidence using urine protein results to manage CKD. Challenges in evaluating and managing proteinuria have been reported in other studies whereby, in Tu et al., urine albumin-creatinine ratio was the most poorly used indicator of CKD. Concerns are that primary care physicians are missing a subset of CKD patients who have proteinuria with a normal eGFR by not using urine studies regularly, or they may be delaying treatment when they are unsure of what to do with abnormal results. There were 3 perceived barriers that physicians strongly agreed with, that being patients unable to afford recommended CKD care, non-adherence with medical management, and long wait times to specialty care services. The COVID-19 pandemic led to new and worsening financial constraints from temporary or in some cases permanent unemployment. There was increased use of herbal medicines, which potentially led to the discontinuation of chronic medications. And the prolonged suspension of face-to-face public specialty care outpatient services made it difficult for patients to get appointments. And all of these can lead to the development and/or progression of CKD in our patients. There were 26 unique barriers revealed in this study, and many of them can be linked to the perceived barriers. For example, non-adherence with nephrology appointments may be due to patients' limited understanding or fears or beliefs about CKD. And for lack of local CKD CMEs, participants had already overall agreed with primary care physicians lacking awareness of CKD guidelines. And finally, difficulties of referring patients from private to public services stems from the non-acceptance of private referral forms, which leads to increased patient volumes at the community clinics, increased frustrations, and ultimately delays in treatment. There were few limitations in this study, the main one being lack of an official list of primary care physicians in the Bahamas, which made the process of exclusion more tedious than expected. Some recommendations include the development of a national CKD guideline, local CKD continuous medical education, an online referral and appointment platform, and more CKD public health education. In conclusion, this study highlighted deficits in the evaluation and management of chronic kidney disease along the lines of bone disorders, metabolic acidosis, and proteinuria, and it revealed numerous barriers. Future studies are needed to further explore CKD at the primary care level and incorporate views of our nephrologists. I would like to acknowledge my research team, Drs. Pinder Butler and Grant, Mr. Fountain, and my research assistants, Drs. Wallace Bain and Sherman Knowles, and the UWI SCMR library staff. These are my references. Thank you.
Thank you, Dr. Will Bain, for a very important study. Are there any questions for Dr. Bain? So, Dr. Bain, recently SGLT2 medications have been shown to have great benefit in terms of delaying and maybe even regression of CKD. Was any information gleaned in your study in regards to those types of medications?
Thank you for the question, Dr. Williams. So in my study, the focus on medications when it came to chronic kidney disease were more so along the lines of use of ACE inhibitors and ARBs. Because the SGLT2 inhibitors were more of a new recommendation, the purpose of this study was to basically find out what kind of groundwork information or practices that the current primary care physician pool we're doing. So we didn't want to include the SGLT2 inhibitors or any other newer medications on the market in the study. In addition to that, the questionnaire had also had a list of common drugs used in primary care, and physicians were asked to determine whether those drugs required renal adjustments. And so that was something that was gleaned out in terms of, physicians were quite aware that some of the fluoroquinolones like ciprofloxacin and other antibiotics like Bactrim should be renally adjusted. And then there were some other medications that, we kind of thought that physicians should have known. And so hence the recommendation for more CKD, continuous medical education, and also some kind of, application that we could kind of forward out to everybody so that persons are aware to look up medications prior to giving them out to patients.
Thank you, Dr. Bain. And we will take one last question. Dr. Cooper, please.
Hi, Dr. Bain. One quick question. You mentioned the necessity of having some local or national CKD guidelines. How would those differ from? You can give me maybe one or two examples of specific guidelines for our population that would differ from international guidelines.
Right. Thank you for the question, Dr. Cooper. So the guideline would be more so tailored to our population. We are a predominantly Black population, and that in itself is an increased risk for chronic kidney disease. In addition to that, the guidelines place certain investigations and frequency in which those investigations should be done, but we are in a resource limited country. And so here comes the question about, well, what are physicians to do who are on the family island, and what are physicians to do who are seeing patients at the community clinic who can't afford to get certain tests? So certainly, if not a guideline can be created, then a consensus statement that would at least outline, based on current international guidelines, this is what we would like our physicians to do. This is when we would like our physicians to refer, and this is how we would like our physicians to manage complications of CKD. Because as you can imagine, based on my last count, we have 8 nephrologists for the country. And so based on the 2017 study, there were 35,000 cases of all-stage CKD. So if you divide that up, that's approximately 4,500 CKD patients per nephrologist. So there's no way that they can maintain or even see all of those patients. So hence why the primary care physicians need to be better equipped to manage these patients.
When do primary care physicians refer to nephrologists? Was the question. The answer, it's recommended to refer patients from stage 3. So certainly if you have made the assessment that you have a patient with CKD3, then you should refer to a nephrologist. And in that referral, you should also include your ultrasound so that they can have information and be able to make some decisions, reasonable decisions with your referral. Thank you for that question, Dr. Van Toren.
I have a simple question. Why are private referrals not accepted or approved of?
Thank you for the question, Dr. Bloomfield. So that is a system level barrier. And so that would have to be changed from the realms of PHA. And so we have persons like myself who see patients coming to the community clinics. They have to get that referral form rewritten either on the government form, or now that we have NHI in place, the NHI referrals are accepted up at the community clinics, up at the specialty outpatient care clinics.
Thank you, Dr. Bain. And so that would have to be a collaboration. I think that most primary care physicians are probably affiliated with NHI. That would have to be a collaboration between NHI and PHA officials to see how that might be able to be moved forward.
Absolutely. Thank you.
Okay, so our next presenter is Dr. Nadia Miller-Edgecombe. She is a SHO in the Department of Pediatrics. Her presentation today will be on the evaluation of caregivers' satisfaction with telemedicine in the outpatient pediatric hematology clinic at Princess Margaret Hospital in Nassau, Bahamas, during the COVID-19 pandemic. Dr. Miller-Edgecombe, the floor is yours. Welcome.
So good morning. My name is Dr. Nadia Miller-Edgecombe, and I am currently a registrar in the pediatrics department. My topic was evaluation of caregiver satisfaction with telemedicine in the outpatient pediatrics hematology clinic at Princess Margaret Hospital in Nassau, Bahamas during the COVID-19 pandemic. And my co-authors were Dr. Corinne Sinqui and Dr. Anthony Frankson. So this is a brief outline of what I will be touching on today. So my introduction. The SARS-CoV-2 was declared a pandemic by the World Health Organization in March of 2020. This then led to global mandatory lockdowns, including suspension of outpatient care. Telemedicine was then introduced to allow continuity of care while adhering to these social distancing protocols. This was particularly useful in caring for patients with chronic medical diseases, such as those with sickle cell disease. So my justification for doing this research topic: globally, telemedicine is used to provide medical care to those with limited access. Given the geographic makeup of the Bahamas, with us being an archipelago country, telemedicine would be a beneficial alternative to traditional face-to-face outpatient management, allowing for flexibility in patient care. This study would evaluate the effectiveness of telemedicine from the perspective of caregivers of a select group of pediatric population here at the Princess Margaret Hospital. So my objective was to assess the caregiver's satisfaction with the implementation of telemedicine during the COVID-19 pandemic in the pediatric sickle cell disease clinic at the Princess Margaret Hospital. So this study was a cross-sectional one, which took place in the outpatient clinic setting. The target population were caregivers for children with sickle cell disease who attended the pediatric hematology clinic during March 2020 to April 2022. The data was collected during the period of February to April 2022. So after going through clinic records, it was noted that there were a total of 116 caregivers that attended the pediatric sickle cell disease clinic during the time frame. Out of those 116, only 66 were able to be contacted. And out of that 66, it was noted that 63 of those caregivers had children with sickle cell disease who were less than 18 years of age. 3 of the caregivers that were contacted either had children who were older than 18 years of age or had other blood dyscrasias. So results that we got from the study, one of the things we wanted to look at was whether the number of visits that the patients had pre-pandemic and post-pandemic was maintained, or was there a difference? And as you can see here, with the blue bar representing those visits that were pre-pandemic and the red bar representing those visits during the pandemic, you can see the majority of patients were able to maintain the 3 to 4 visits every year. Another variable that we went through in the study was whether participants were satisfied with their telemedicine experience. And we asked them if they felt as though the caregiver cared about them a lot, somewhat, or not at all. And 74.1% of participants noted that the telemedicine provider cared about them a lot. 59 caregivers noted that they were very satisfied with the level of care received via telemedicine. The third variable we explored was some of the perceived disadvantages to face-to-face outpatient care. So the caregivers were allowed to select more than one disadvantage. And as we can see here, that time away from school was the one that received the highest concern with the disadvantage of face-to-face clinic visits. And then lastly, we wanted to know whether these caregivers would be open to continuing telemedicine in the future when it came to outpatient care for their child. And the overwhelming majority, so 70.5%, actually desired to continue telemedicine for the pediatric sickle cell disease clinic. And out of that 70.5%, over 50 of those over 15, so wanted to have at least half of the visits be via telemedicine. So in the discussion, we can note that the standard healthcare visit of having a visit every 3 to 4 months was maintained, which was a positive. So we know that with the use of telemedicine, it could be added and there would not be any disruption in the amount of visits that our patients experience. And then also the number of patients that were lost to follow up, meaning that they had no clinic visit, was actually remained constant throughout the entire study. Most caregivers desire to continue telemedicine post-pandemic, and this may tie in with the fact that majority of them found that time away from school or work was their greatest disadvantage, despite knowing that the risk of their child contracting COVID-19 put their child in a very precarious position. So limitations that were noted in the study: recall bias from participating caregivers. Also, it was noted that the clinic records did not actually delineate what the diagnosis of the child was that came to the clinic. So it was very hard to know how many persons were actually met the criteria to be included in the study. And also the outdated record keeping that was done in the clinic made it very hard to contact a lot of the parents. So in conclusion, we saw that telemedicine was received favorably amongst caregivers. The number of patient clinic visits remained consistent when comparing pre- and post-COVID-19 visits. Accurate record keeping remained a very huge limitation during the study. And we hope that from this study, that telemedicine can be now used to provide an adjunct to future outpatient care. I would like to acknowledge Dr. Sinqui, Dr. Frankson, Dr. Christina Wells, Dr. Rashonda DeVoe, and Mrs. Phillips for their help with this project. These are my references. Thank you.
Thank you so much, Dr. Miller-Edgecombe. Are there any questions for Dr. Miller-Edgecombe at this time? So, Dr. Miller-Edgecombe, we know that old habits die hard, and so we tend to return to the ways of old. I suspect that you probably now fully back to in-person visits. Do you see going forward, based on the desire to continue with virtual visits, do you see that being the adjunct that you suggest that it might be in the near future? And how would that be implemented?
Right. So what we have actually started doing very recently, we know a lot of times parents don't come, or I should say patients don't show up to their clinic visits. So we have an SHO assigned that would go and conduct a somewhat telemedicine visit with those patients that actually missed the previous clinic visit. And it's a way for us to just ensure that all is going well and that these patients are adhering to guidelines. So we have, in a way, sort of started with those patients we notice are missing clinics.
Do you have any idea of the percentage default that you have in clinics?
So from the study, it was not so how I could say from the study, it was surprising. We were actually able to reconnect with patients that were lost to follow-up because they never did face-to-face. But it was still a very small percentage. It was about 3% of patients that were lost to follow-up.
Thank you so much. Are there any other questions for Dr. Miller-Edgecombe? Okay, thank you.
Yes, one question.
Dr. Sankey?
Thank you. Just wondered, Dr. Edgecombe, what do you think would be the benefit to the institution for maintaining telemedicine visits as a part of the overall clinic visits for the patients? Because you talked about the benefits to patients and to caregivers. What do you think would be the benefit to the institution?
So in terms of the institution, it will help with overall costs because we know a lot of times clinics can become overcrowded with patients. And then we have to now hire physicians to meet the demand of the community. So by allowing to have flexibility in the way we conduct our clinic visits, we could hopefully defer some of the cost and then some of the clinics becoming so crowded as well.
Thank you.
Thank you, Dr. Miller-Edgecombe. And so we will go now into our next presentation, which will be done via video. Dr. Amanda Ramming O'Neill is a physician in the Department of Pediatrics. Her topic today is adolescent attitudes toward COVID-19 vaccination and actual uptake in New Providence, the Bahamas, during the 2022 phase of the pandemic. Please, can we roll the video?
Hello, everyone. My name is Dr. Amanda Ramming O'Neill, and my DM project report was entitled Adolescents' Attitudes Toward COVID-19 Vaccination and Actual Uptake in New Providence, the Bahamas during the 2022 phase of the pandemic. Dr. Marcia Bassett was my principal investigator, and Dr. Anthony Frankson was the epidemiologist and biostatistician. Just some background information about COVID-19. At the end of 2022, there were over 600 million global cases of COVID-19 infections, and there were over 15 million of these cases reported in children in the United States. Globally, there were about 17,400 deaths reported in those under 20 years of age. 33 of these deaths occurred among children from Haiti, Jamaica, Trinidad and Tobago, as well as Barbados. It was noted that there was an increase in symptoms of anxiety, depression, and fear in the adolescent population due to home confinement. The CDC has proven that COVID-19 vaccination reduced the rates of morbidity as well as mortality. However, vaccine hesitancy was an obstacle that has yet to be faced. It is one of the 10 threats to global health according to the World Health Organization, and it is defined as a delay in acceptance or refusal of safe vaccines despite availability of vaccination services. And this was also seen amongst adolescents in the US. So the rationale for my study, vaccination of children and adolescents was proven to be crucial in reducing disease burden, as well as to facilitate the reopening of school, which is vital to the well-being of children, as well as parental participation in the economy. However, vaccination hesitancy and willingness had not yet been explored in the adolescent population in New Providence. So my research question was, what were adolescents' attitudes towards COVID-19 disease and vaccination in New Providence, the Bahamas? My objectives were to ascertain levels of awareness of sound options for prevention of COVID-19, to estimate the level of COVID-19 vaccine uptake in adolescents ages 12 through 19 in New Providence, and to determine participants' status regarding their willingness versus hesitancy for COVID-19 vaccine and the factors influencing this. We had estimated that at least 50% of participants would be aware of sound options for COVID-19 prevention, but that the rate of COVID-19 vaccine uptake would be low. This brings us to my methods. The study procedure was a cross-sectional study design, which involved 239 students in New Providence in public high schools. Consent and assent was obtained, and it was a cluster random sampling of 7 public junior and senior high schools in New Providence, the Bahamas. And the study was limited to New Providence due to resource and time constraints, and it was distributed face-to-face by the researcher. Joint ethical approval from Public Hospitals Authority, as well as UE School of Research and Clinical Medicine, was how ethics approval was obtained. Additionally, from the Ministry of Education. And the study was done during June to July of 2022. The questionnaire was adapted from a Swedish mixed method study about adolescents' perspective of COVID-19. Disease knowledge, vaccine hesitancy, and willingness was also measured. There was also a segment where adolescents provided their thoughts on ways to encourage increased uptake. And some of these questions included, do you think COVID-19 vaccination stops spread of disease? Are you vaccinated against COVID-19? Would you like to be? And list ways to encourage teenagers to say yes to a COVID-19 vaccine. Descriptive and inferential statistics were performed on all variables in the questionnaire, and measures of central tendency and dispersion were used. And these included percentages, means, medians, and modes. Measures of dispersion included standard deviation and interquartile ranges. There are also measures of association on the variables in the study, and bivariate and multivariate analyses were performed. So, what did we determine? So out of the 239 participants, there was a predominance of female participants, with 142 females participating and 96 males, about 40%. The modal age of participation was 14. The mean age was 14.2. And this is because most of the students were in the 9th grade, as you can see, which was the modal grade of participation. And the school with the most participants was H.O. Nash Junior High School. So, what did we determine? The median frequency of which the 95 males wore their masks was always, and for the 140 females was also always. The frequency of social distancing was also noted to be predominantly high. Most students reported sometimes, some said often, but hand hygiene proved to be pretty high, with 160 students admitting to always washing their hands. So when participants were asked about their thoughts of whether or not COVID-19 vaccine prevented disease, over 100 said maybe, about 50 participants said no, and about 80 said yes. So there was a high degree of uncertainty. When analyzing participants' vaccination status, as you can see, there there was a predominance of participants not being vaccinated, and there was a high degree of hesitancy as well as unwillingness to receive a COVID-19 vaccine. And this final predictor model represents a 3-predictor multivariate logistic regression, which had an 82.2% accuracy in identifying the variables which would make a participant say yes to having a COVID-19 vaccine. So if they thought that yes, a COVID-19 vaccine prevents disease, they were 8 times more likely to say yes to wanting a vaccine. If their caregivers were vaccinated, they were almost 2.5 times more likely to say yes to a vaccine. And if any of the participants had a family member that tested positive, they were almost 3 times more likely to say yes to a vaccine. And this slide talks about ways in which participants were encouraged to share how we can get more adolescents to say yes to COVID-19 vaccine. The funny one I thought was, monetary incentives, as you can see, that came in kind of high at 22.9%. But more than 50% of the adolescents felt that the benefits should be openly communicated, as well as working overtime to dispel myths about the COVID-19 vaccine. So what we found from the study was that the perception of the ability to use protective measures was relatively high. However, there was a high degree of hesitancy and unwillingness for a COVID-19 vaccine compared to other regions. In this study, caregivers had a higher rate of COVID-19 vaccine uptake compared to their children. Participants responded to having, out of all the participants, 65.3% of their caregivers were vaccinated versus 36.1% of participants. So what's new with COVID-19 vaccines in pediatrics? So we realized that there is still more work to be done. Now, the federal COVID-19 Public Health Emergency Declaration ended on May 11, 2023. However, at the end of September, the number of children under the age of 18 with confirmed COVID-19 at hospital admission increased nearly 5-fold from 237 new admissions the week ending June 17th to 1,175 in the week ending September 19th. And hospitalization rates increased for all children, but especially for children under 5 years old who are at the highest risk. And, this is in keeping with the rate of uptake. In the 12 to 17 year age group, their rate of vaccination is 68% versus only 13% in children 6 months. And the American Academy of Pediatrics recommends that the coronavirus vaccine should be given to all infants ages 6 months and older. So there is still more work to do, and COVID is still out there, and children are still being hospitalized. So in conclusion, pediatricians are encouraged to promote vaccination and vaccine confidence through ongoing proactive messaging, reminding parents, as well as using existing patients as an opportunity to promote and provide COVID-19 vaccines. And we're going to continue to advocate for COVID-19 vaccination amongst all children as well as adolescents. So these are my references. Thank you for your time.
So moving right along, our next presenter is Dr. Charles Lucas, who is a surgeon in the Department of Surgery at PMH. He's recently completed a fellowship in vascular surgery in Canada, and we've had the pleasure of listening to a couple of his presentations already. This morning, he will be doing a presentation, a case study on open repair of a brachial artery aneurysm that developed after hemodialysis fistula ligation in a renal transplant patient. Dr. Lucas, the floor is yours.
All right, thank you for that warm greeting. All right, so this is an interesting case study, and I sort of entitled it "A Massive Problem," a little tongue-in-cheek. I have no relevant disclosures. This is a table of contents. Now, true brachial artery aneurysms are rare. Less than 1% of peripheral artery aneurysms are brachial artery aneurysms. And they're also extremely rare in transplant patients, especially those who've had prior ligation with their fistulas. In the literature, the etiology is mainly related to infection, trauma, or iatrogenic. In our case, we had a gentleman in his 70s who presented with progressive tingling, in his fingertips to his left hand. He was hypertensive, had dyslipidemia and diabetes. And he had a brachiocephalic fistula that was ligated almost 25 years prior. He had a successful renal transplantation, and he was on the requisite suppression medication. On examination, he had a large palpable pulsatile mass in the left arm, extending from his shoulder to the elbow. Bedside ultrasound showed a large brachial artery aneurysm with significant clot burden. And this is a sagittal CT showing the bilobulated aneurysm. In the proximal arm, it measured 5 by 5 centimeters. You can see that there's still central flow, but there's significant clot around. And distally, it measured almost 7 by 8 centimeters, and it was completely occluded by clot, the thrombosed. So the assessment was a large symptomatic brachial artery aneurysm, and the plan was for open repair. He was given preoperative antibiotics, and this is an intraoperative photo showing the large aneurysm. We're just beginning to dissect. Sorry. And we got distal and proximal control. You can see the vessel loops in situ. The proximal anastomosis was the distal axillary artery, really, and we were anastomosing a ring PTFE graft to it. This is more distally. Now, his radial artery was chronically occluded. We oversaw that and did a distal anastomosis with the PTFE to the ulnar artery. This is the completion photo, and what we did is wrap the PTFE graft in part of the sac. Most of it was excised to help with stability. Intraoperative Doppler showed flow through the graft and distal outflow in the ulnar artery. Postoperatively, he remained intubated because of intraoperative hemodynamic instability, and he was taken to the ICU. Unfortunately, there was a complication, and we'll get to that right now. Hours after getting back to the to the ICU, we noted that he had absent pulses. Sorry, 1 second. We did a bedside duplex ultrasound that showed no flow in the ulnar artery, and the assessment was that of a occluded graft, likely due to a technical failure. And he was taken urgently back to the operating theater. Our re-exploration, we noted that there was a faint ulnar signal, but it was positional. So depending on where we moved the arm, the flow would completely cease. We were able to retrieve fresh clot with a number 3 Fogarty embolectomy catheter, and we ultimately diagnosed that the graft had thrombosed due to kinking. What we did to correct this, we shortened the graft and reapproximated in tension-free manner using 6-O-proline. There was resumption of excellent flow through the graft. We tested this in multiple positions, again, because of the length of replacement and the how much dead space there was because of the aneurysm, the stability of the graft. We really had to test. He was extubated and he returned to the ICU in stable conditions. Postoperatively, he had significant arm swelling, so much so that we did an ultrasound to rule out DVT, but there was none. The swelling was treated with diuresis, compression, and arm elevation with good effect. He was discharged about 7 days post-op. We did follow him up at 2 weeks and again at 8 weeks. By 8 weeks, he had significantly less tingling in his hand and there was no numbness. Did a normal motor function examination, and he was able to subjectively use his hand without any issue. In terms of brief discussion, these brachial artery aneurysms are usually symptomatic only a third of the time. They can present with a palpable mass or paresthesia due to compression, and also they may present with thromboembolic complications such as ischemia to the hand. The usual time to presentation for those who had fistular ligation prior is actually 20 years, which is in keeping with our case. And there are only a few case studies that actually have looked at this. In terms of the theories surrounding its pathophysiology, one is that there may be increased wall stress due to the high flow of the AVF. But this doesn't explain why many brachial artery aneurysms occur years after fistula creation. Another suggestion is that there's long-term damage to the elastic fibers, which puts the artery at risk of aneurysmal degeneration even after ligation. And there's also a suspicion of the role of the immunosuppressive medications that renal transplant patients often are on that may accelerate arterial dilatation. Management is usually open surgery. And as in our case, you can use an interposition graft, either vein or prosthetic. Vein conduit can be used. In this case, you could use a deep vein because of the large size. And they're associated with less morbidity overall. We chose to use a ring PTFE in this case because of the size of the proximal artery and the length of graft required, as well as the extra support needed in this particular case. Another alternative would have been to use transposition of the superficial femoral artery. Endovascular treatment is rarely used in these conditions. So operative repair is generally well tolerated with excellent long-term results. One case series shows that you can expect symptom relief almost completely by like 16 months with almost near 100% patency rate. In conclusion, true brachial artery aneurysms are rare. Symptoms are usually due to compression of the adjacent structures, as well as due to embolization. These aneurysms can expand to impressive size, as described in this case, and operation is usually curative, but can be very challenging. So this case really spurred me on to create a surgeon-led database at the Princess Margaret Hospital for our end-stage renal patients who require dialysis. We try to capture information related to epidemiology as well as comorbidities and relevant medical illnesses. We also, importantly for the surgeons, document current as well as previous access. And I want to thank Dr. Taylor and Dr. James, who also helped spearhead this. And so we have full participation from the renal transplant service as well as the cardiothoracic service. Dr. Farquharson and myself in the vascular surgery team. Thank you so much, and I just open the floor for questions.
Thank you, Dr. Lucas. Are there any questions for Dr. Lucas at this time? So as you suggested, Dr. Lucas, it is a rare occurrence that you may get an aneurysm of this type. Certainly greater than 20 years, we would be so fortunate if we were to get many people live that long who get dialysis. Do you have any idea, given that it takes so many years, of the numbers that do exist? I know that you say rare, but are there any numbers per 100,000, per million that you can give us?
Hello?
Yes, we can hear you.
Hi. Yeah, so the challenges, especially after ligation in these renal transplant patients, as you said, one is that the long-term follow-up required just isn't there in many parts of the world. Two is a rare condition that is probably not on the radar of most physicians. So we don't really have a lot of data. The largest case series I found was like 13 patients. So we think is extremely rare. Of those patients who present with peripheral aneurysms, we think is like 0.1% of all of these cases. So I think in the Bahamas, we may never come across it. But I think it highlights the fact that once these patients with end-stage renal disease, they need access for hemodialysis. They're basically surgical patients for life. We need to continue to monitor them and keep them on our radar. I think it's important that the whoever's performing the access surgery keep track of these patients and are available for consultation. I think that's basically the take-home message.
Thank you so much, Dr. Lucas. Are there any other questions for Dr. Lucas?
Just a quick question, if I may, Dr. Taylor here.
Yes, go ahead.
I just wanted to know how you felt, Dr. Lucas, about going straight to brachiocephalic fistula instead of a radiocephalic fistula in the end-stage renal disease patients who need an access, since this complication, although rare, does exist.
Dr. Taylor, thank you. And I just want to thank Dr. Taylor for being on the call. He's doing a lot of great work with our access patients, and as well as spearheading the renal transplant in the Bahamas. I think for me, I know we've moved away from the previous KDOQI guidelines in terms of starting distally, and we want the right fistula or the right access for the right patient at the right time. There's a current mantra. I personally think, though, that we should strive wherever possible to use the distal accesses, so use your radiocephalic before going to brachiocephalic or using more proximal accesses. The reason being is that these patients, especially the younger ones, will be receiving hemodialysis indefinitely. And as we work to beef up our transplant patients, getting more transplants, these patients will almost invariably have a complication of their access and need revision. And I think we know of quite a few patients who have no options in terms of access. I think to answer your question, I think personally, I believe we should all strive to use a radiocephalic, even if it is not as ideal. We know the guidelines, you want at least a 2 millimeter artery distally, and for the vein, 3 millimeters would be ideal. But I think even if you have a suboptimal radiocephalic fistula and is used for a couple of months, a year even, it goes down or needs some remediation, I think it's better than jumping straight to a brachiocephalic. Then that probably may work well, failing, and then we have few other options. I think we're also doing work to look at our graft complications and use of prosthetics, particularly, and they have a higher complication rates, and we think it may be even higher in our neck of the woods. So where we can use autologous grafts, which are better suited for the distal accesses, are more common. I think we should strive for that wherever possible. I don't know. I hope I can answer your questions. I'd like to hear your thoughts on it as well, or any other vascular surgeon who's on the call. Thank you so much.
Thank you, Dr. Lucas. So we are going to move into our final presentation of this session. And this is by one of our recent graduates of the pediatric residency, Dr. Anthea Forbes Carey. She is now stationed at the RAND in Grand Bahama. Her presentation today is on the prevalence of adverse childhood experiences in urban communities in the Bahamas. Welcome, Dr. Forbes Carey.
And so thank you for the introduction. My presentation and my research was on the prevalence of adverse childhood experiences in the urban communities in the Bahamas. The principal investigator for this was Dr. Marcia Bassett, and other co-investigators were Dr. Sharnika Knowles and Dr. Morton A.C. Frankson. And so just a little outline. I'll go through the introduction, the lit review, the aim of the study, the objectives, the methodology, the results, recommendations, and conclude. And so when we look at potential traumatic events, these actually reshape the developmental experiences in childhood from birth to 18 years in multiple dimensions. Those dimensions are spiritually, mentally, emotionally, physically, and socially. So having a screening tool implemented can actually assess the ACEs, the adverse childhood experiences. It has been of vital importance in efforts to measure the impact and the implications of the early part of life. And this is actually from the CDC in 2019. Prolonged exposures and considerable amounts of these adverse childhood experiences actually have lifelong consequences for a person's health and well-being. That's also from the World Health Organization from 2018. Healthy development is essential in the early years, as we know, especially between the ages of birth to age 3, to provide the essential building blocks and personal tools that are required for the academic and educational achievements, also for economic productivity, lifelong health, creating responsible citizens, building stronger communities, and creating successful parenting skills for our next generation. And this was also from Harvard 2017, an article. So implementing the ACEs screening tool in a public healthcare sector would actually be a positive step towards quality improvement in our pediatric healthcare. And it could be of great assistance in creating a standard of care, increasing provider awareness, and providing early intervention for our children who are dealing with trauma resulting from these adverse childhood experiences. And so on the lit review, the emotional well-being, social competencies, physical health, with the linguistic capabilities all stem from the early years of life. And these are very important precursors for future success in the school setting and later on in the work environment and in the community. And so persistent chronic stress has its negative influence, as we know, on the brain and the architecture of the brain. And this is from an article from Bruce McEwen in 2017 and from Harvard 2017. The Adverse Childhood Experience Study is a research that was conducted by the United States Health Maintenance Organization, Kaiser Permanente, and the CDC. This study was actually conducted from the years 1995 to 1997, and it did show an association of adverse childhood experiences with social and health challenges across their lifespan. The participants in this study was actually asked about different types of ACEs, such as the physical abuse, physical neglect, emotional abuse, emotional neglect, sexual abuse, domestic violence exposure, household substance abuse, mental illness, being in a home where the parents are divorced or separated, and also being in a home with a member who would have been incarcerated. And so there exists a strong relationship between the breadth of exposure to this household dysfunction and abuse during the child's childhood. And so there exist multiple risk factors for several of the leading cause of death in the adult population, and it does include ACEs, and this is from the American Journal of Preventative Medicine in May of 1998. The CDC in 2019 reported and revealed that the individuals with 4 or more adverse childhood experiences had actually suffered greater odds for suffering from cancer, heart disease, stroke, chronic lung disease, diabetes, suicide, obesity, depression, illicit drug use, smoking, and sexually transmitted diseases. So these ACEs are prevalent, but they are preventable. Statistics do show that 1 out of 7 children would actually have experienced child abuse and or neglect within the past year, which is possibly an underestimation. That's from the CDC 2019 report. Children living in poverty tend to experience more abuse and neglect than others. So the rate is estimated to be about 5 times higher in children with families who are struggling and who have lower socioeconomic statuses, and that's from CDC 2019. So the economic burden on the mistreatment on children is actually a costly one. So for the aim of the study, it was to assess adverse outcomes from the adverse childhood experiences and the demographic correlation in the pediatric population in the Commonwealth of the Bahamas. The rationale for the study would actually be groundbreaking in the Commonwealth of the Bahamas, because currently the ACEs tool survey, which is such a vital tool, is not being used in hospitals or clinics. And so implementing this tool would actually increase the awareness of the providers, and it would also create a new standard of care for the pediatric population. Looking at our objectives, the objectives of the study were to determine the adverse childhood experiences, the prevalence, determine comorbidities and other outcomes, and determine correlations from the demographics and the adverse childhood experiences. For the methodology, and so the setting for the study was in high school classrooms, in which adolescents completed a survey after obtaining their parental consent, giving both consent on the islands of Grand Bahama and New Providence, and they provided us with that consent. And bearing in mind that Grand Bahama and New Providence are the 2 most populated islands in the Commonwealth of the Bahamas, and our adolescents actually make up 12.5% of the Bahamian population. And so this was a cross-sectional study that was done. It was designed to conduct this study. And the targeted population, as mentioned, were the adolescents attending the public schools in the Bahamas. And so These students were in grades 10 through 12 in the government-sponsored schools that they attended. And so the ethics committee approval was granted prior to the data collection, and the Ministry of Education as well, they were involved, and they gave their approval for the study to be carried out in Grand Bahama and New Providence using the governmental high school facility, and with the support of the parents as well, largely willing to give consent, and likewise students providing voluntary assent. And so the students attending grades 10 through 12 in the schools completed the survey as provisions were made to ensure that the privacy was there for them. And also these surveys were anonymous. So the Adverse Childhood Experience Questionnaire was used, and it was tailored to include age, sex, nationality, and their school grade. The questionnaire covered the adverse childhood experiences such as the verbal abuse, humiliation, physical abuse, sexual assault, neglect, violence against a mother or stepmother, residing in a household with a member who would have been to prison, residing in a household with a member who used street drugs or alcohol, and residing with a family member that has mental illness. So in this study, 550 high schools in the Bahamas participated, and of these, 31.8% were from the island of Grand Bahama, while 68.2% were from New Providence. The race was noted to be predominantly Black. There were various nationalities. 81.8% were Bahamians, and the others were Americans, Haitian, Jamaican, Ukrainian, and also the Dominican Republic. The ages, as mentioned, were 14 to 19, with 50.8% being males and 49.2% being females. And so as we look at this with regards to the 10 variables that I outlined that were used, when these participants looked at, when they completed the survey, we realized that a sum to form a scale scoring indicating adverse childhood events, the frequency distribution revealed that 69.5% of the participants had experienced 3 or less adverse childhood experiences, while 30.5% experienced 4 or more adverse childhood experiences. And so based off of those findings and those results, we had recommendations from a health perspective, community, budgetary, finance, and technological, policy, and from a research perspective. And so starting off with the health, there are networks of care that provide a trauma-informed approach to address these ACEs and toxic stress. Being able to access these networks, whether they're locally or internationally, would be great. We want to establish these networks of disciplinary healthcare, education, human service professionals, members of the community, organizations that are equipped and able to recognize and respond to any signs or symptoms of trauma and ACEs, and be able to provide a resource to mitigate any harmful consequences. And so health programs should be established in the schools and in the community clinics. Strong referrals with surveillance should be processed in the community. And resources should also be made available to anyone and access to any ACEs support groups. Family life programs are also important. And so for the community, the roadmaps need to be identified with strong leadership and accountability structures, being able to connect with healthcare teams and resources, achieve community and health integration, assess the financial and technological needs, and be able to continually improve on the strengths of the network care program that would have been created or that needs to be created. With regards to budget, finance, and technology, the recommendation is for there to be funding sources that need to be identified, partners selected, budgets implemented, and to ensure that we have appropriate healthcare platforms to support the ACE program. Policies. So with regards to the policies, it should be enforced on the existing laws regarding the adverse childhood experience. Relationships should be strengthened between the government, ministries, NGOs, and the international organizations to better provide resources and create more effective programs against the adverse childhood experience. And of course, more research. We need to do similar cross-sectional researches. They should be conducted at least every 3 years and have ongoing surveys in the school sector. And so in conclusion, the study identified the prevalence of adverse childhood experiences in the Bahamas on the 2 most populated islands in the public school sector. This study can be used as a starting point. The study supports the need for pediatricians and other clinicians in the Commonwealth of the Bahamas to routinely screen for the adverse childhood experiences, as it does highlight the importance of future work that's needed. We need to identify the interventions that are needed and to mitigate and prevent any of the exposures to the adverse childhood experience. It also provides us with the opportunity to intervene for those identified as being exposed, and we need resources against ACEs, that these should be made readily available in all of the healthcare settings. And so, as Nelson Mandela quoted, the true character of a society is revealed in how it treats its children. These are my references. And I'd like to send a special thank you to everyone who would have assisted with this research project. Thank you.
Thank you so much, Dr. Forbes-Carey. Dr. Misty Spencer-Prince, excellent work. We do need to have a treatment protocol in place. So, Dr. Forbes-Carey, thank you for your study. We are happy that you were able to go outside of New Providence and conduct a study. Did you notice any differences between the population in Grand Bahama to that of New Providence, or were they consistent?
I found them to be consistent. In this study, we actually looked at the responses from Grand Bahama and from New Providence, from the various schools and age categories, and looked at those 10 questionnaires just to see if the responses would have been different. And we found them to be pretty similar.
And in your study, you showed that 69.5% of the population had 3 or less of the other signs. Does that include 0 in that count? Because 0 is less than 3. Or
yes, 0 was included in the count. That is correct.
Okay, so do you have any numbers as it relates to those who actually had no signs of adverse encounter?
So those numbers we do have them, and those were on the lower end, who actually would have had no encounters. There were students who actually had no encounters. The encounters were 0. And so, but those were lesser numbers. It was a very small number.
Okay, thank you. And do you believe that the pandemic, I suspect you would have done your study during that period of time, that might have had any influence on your results?
Absolutely. So during the pandemic was a very challenging time for everyone. And so that actually did, we would imagine that did have an influence on the factors, on the students, the participants, on the parents, and of course on the results. And so, yes, we found that it did have an influence in a negative manner on our students in the Commonwealth of the Bahamas.
Thank you. So from the chat, Dr. Homer Bloomfield, excellent work. Greater community support is important. Dr. Spencer, again, if we are able to address these ACEs with respect to providing definitive treatments, we could possibly have better success at getting more sustainable and positive results in disease treatment. Do you wish to comment?
No, I agree.
Great.
That's certainly the objective.
I think that session 5 has been an excellent session. We appreciate all the speakers for their presentations this morning. We have lived up to our time requirements. We thank you, the audience, for your attention and for your participation this morning. Just a few housekeeping matters. As you are aware, if you are not registered and you wish to get CMEs, we invite you to do so. And we also encourage you to complete the evaluation forms for persons who wish to get CME credits. The completion of the evaluations is critical, and the sooner that everybody is able to complete their evaluations, the sooner the research team will be able to get final sign-off from the Medical Council. So I, again, would like to thank you for an outstanding morning. This brings us to the end of session 5. Session 6 and final session will begin promptly at 1 p.m., we hope. We look forward to seeing you, and we invite you to stay on for messages from our sponsors. Good day.
Sickle cell disorders are a group of illnesses which affect your red blood cells. Sickle cell is a genetic condition, which means it is passed on from your parents and you are born with it. You cannot catch it from other people. Sickle cell disorders cause your normally round and flexible blood cells to become stiff and sickle-shaped, stopping the blood cells and the oxygen they carry from being able to move freely around the body and cause pain. Symptoms of sickle cell disorder include chronic anemia, unpredictable pain, fatigue, and jaundice. Over time, people with sickle cell can experience damage to organs such as the liver, kidney, lungs, heart, and spleen. Treatment of sickle cell mostly focuses on preventing and treating complications. If you notice any symptoms of sickle cell disorder in yourself or someone you know, schedule an appointment with your doctor. This message is brought to you by the Public Hospitals Authority.